Ladies and gentlemen, welcome to APCCMI in Singapore, also virtual meeting. This is Pfizer-sponsored symposium talking a very important issue, evolution and emergent issue for optimized invasive mold infection management in Asia. I'm Chen from National Taiwan University Hospital and College of Medicine. This is a disclaimer for this symposium. There are three objectives for this symposium: to share updates on the current practice of managing invasive fungal infection and the role of novel antifungal agents, to provide an interactive platform to discuss optimized outcome of patients with invasive mold infection, from diagnosis to treatment, to share experience on the gap and challenge in managing invasive fungal infection in the clinic and a practical way to overcome them. We have two special international outstanding speakers. The first is Professor Agrawal, and the second is Professor Chakrabarti, to give us two talks, including diagnostic-driven approach and the latest landscape and challenging in applying gold standard in clinical practice in Asia. Then we have opportunity have a fireside chat and welcome every one of you to give your opinion, suggestion, and question, and we can chat together. And very important, how to submit question for live Q&A. The first, you can click the Q&A button and tap your question and click send. Also, after the symposium, please complete the feedback survey. Your feedback is very important for us to design the future very important symposium. Here, the option 1, click on the link that pop up in the chat box. The second, you can insert QR code and scan the QR code. Please, your opinion is highly appreciated. Here, it is my honor to introduce our first speaker, Professor Samir Agrawal. Professor Agrawal is consultant hemato-oncologist at Queen Mary University of London and the Bar Health NHS Trust in the UK. He's a member of the Fungal Guideline Group of the European Conference on Infection in Leukemia and authors of the ECIL6 update. He's also a member of the fungal subgroup of the NHS England Anti-Microbial Resistance Committee, UK. Dr. Agrawal's research interests including improving the diagnosis of invasive fungal disease in high-risk hemato-oncology patients, developing clinical guidelines and integrated care pathways for management invasive fungal disease, and audit tools to add antimicrobial stewardship. Let's welcome Professor Agrawal.
So good morning, everyone from London. It's morning here. Firstly, I'd like to thank Pfizer for the invitation to talk, to present at the 18th Asia Pacific Congress for Clinical Microbiology and Infection. It really is a great pleasure for me, and also a shame that I can't be with you physically in Singapore for those of you that are attending the meeting there. My name is Dr. Samir Agrawal. I'm a hemato-oncologist in London. I work at St. Bartholomew's Hospital, and you can see some images of the hospital and central London there. The hospital was founded in 1123, the oldest hospital in Europe. I'm being asked to address the question of a diagnostic-driven approach to invasive mold infection and the role of new drugs. And I'm going to do that specifically with the idea of hemato-oncology in the background. One of the things I was asked to consider was, in an ideal world, what would optimal management look like? So let's see if we can see what optimal management might look like. These are my disclosures, the disclaimer, So before we can think about optimal management, I think we need to start with what is the problem, at least as the problem as I see it. And I'll address these other issues here as we go along. So I refer to the roller coaster. So what's the roller coaster? This is the antimicrobial roller coaster. And I think this is probably fairly similar in most centers in the world. Our high-risk patients with acute leukemia and receiving hematopoietic stem cell transplants are given a range of prophylactic antimicrobials on admission. At the development of febrile neutropenia, blood cultures are done, and at least in our practice, these cultures are almost always negative, and we immediately start broad-spectrum antibiotics, and I'm showing you what we do here in our center. For a patient with persistent fever, then frequently, even with negative microbiology, and in a patient who's clinically stable, there may be a change in antibiotics with commencement of a carbapenem and possibly gram-positive cover as well. Now, if the fever continues, we then start thinking about an antifungal drug. And either we start empirically or we perform other tests as shown here in the slide. But if you don't have some of these tests available to you, then can you see how we've gone through an escalating empirical approach with no microbiological diagnosis? So, and this started with the antibiotics and it's continued through with the antifungal drugs. Can we do better? Well, we certainly need to understand who gets invasive fungal disease and who's at highest risk, who merits prophylaxis, and what strategies we can use. Now, this slide is by no means comprehensive, and I suspect that you will all be familiar with the majority of high-risk factors on this slide. I just want to focus on a slightly different setting from hemato-oncology here. So in the intensive care unit setting, patients who have severe influenza pneumonia or COVID-19 are at increased risk of invasive pulmonary aspergillosis, and that's something to be aware of. Now, how do we package all of this into a practical approach in the clinic, in the hospital? And I think it's generally accepted that these groups of patients are at high risk, so acute leukemia receiving intensive chemotherapy, allogeneic stem cell transplant patients, and patients with graft versus host disease. But I just want to make you aware that the landscape is changing. So in indolent lymphoproliferative disorders, such as chronic lymphocytic leukemia, there are now increasing reports of the Bruton's tyrosine kinase inhibitor, ibrutinib, being associated with invasive aspergillosis in this patient population in whom we would not formally have expected this. And there's a very surprising and alarming rate of cerebral aspergillosis in patients who develop the problem of over 50%. Similarly, in the area of acute myeloid leukemia, a slightly different issue, but we now are using a variety of drugs as standard of care, so venetoclax, midostaurin, glitteritinib, which are really making the antifungal management, both prophylaxis and treatment, a challenge. So important to understand that things are changing. Now, in terms of strategy, I'm just going to labor this a little bit just to make sure we all mean the same thing by the words that we use. So empirical treatment refers to treating the patient based on their clinical symptoms and signs, principally refractory fever, and we give antifungal treatment. Now that we have these biomarkers widely available, we can also use a screening strategy in an attempt to diagnose invasive fungal disease before the patient develops significant signs or symptoms by regular testing of the blood. And in a diagnostic-driven strategy, we are again using the patient's clinical signs and symptoms as the trigger, but now we don't give an antifungal drug, we use the testing strategies that we have shown in the box there. And in theory, at least, only if these tests indicate the presence of infection does the patient start antifungal treatment. So I should emphasize here a big difference between guidelines, theory, and perhaps clinical practice, perhaps. If you use mold-active prophylaxis, please bear in mind this has a very powerful effect on your strategy. So mold-active prophylaxis impairs the performance of the biomarker test that we have. So in this context, if you have a patient with refractory fever on good mold-active drugs already, what should you do? Well, it's very important in this setting, using the mold-active azoles as prophylaxis, which are principally the ones shown on this slide, to know whether these drugs are therapeutic or subtherapeutic in the patient. So therapeutic drug monitoring is really key to knowing what to do about treatment in this setting. So the American IDSA 2016 Aspergillus guidelines recommend switching to intravenous therapy, which is reasonable if the drug was subtherapeutic, or changing to another class of drug. Now, I've also just cited here one study which has looked at isovuconazole in the setting of previous mold-active azole prophylaxis or treatment. And interestingly, this study found a 60% response rate in this setting. So perhaps azole after azole is not unreasonable. Of course, in this setting, diagnosis is a huge challenge. I'll talk about diagnosis in the slides to come. I won't say much about stewardship, although stewardship is absolutely key to optimal management in this patient group, and it's also very challenging. So you'll be familiar with these assays. You may be less familiar with the rapid antigen test, which I'll talk about, but all of these are commercially available, approved assays, focusing on Aspergillus infection. Now, with respect to galactomannan, which we've had for over 20 years now, and Aspergillus PCR also been available for a similar length of time, but less as a commercially available assay, I'm going to use randomized clinical studies. So these are two relatively large randomized clinical trials in the hemato-oncology setting. That 2013 study compared an empirical approach with CT scanning versus a biomarker approach. Mold prophylaxis was allowed, and this study found a significant decrease in antifungal use using the biomarker approach, with no difference in mortality in the two arms of the study. Now, the 2015 Spanish paper there was an interesting paper comparing biomarker galactomannan with enhanced biomarker monitoring, adding in Aspergillus PCR, no mold prophylaxis in this study. And you can see once again the data showing similar results. If you enhance your biomarker monitoring, you can rationalize antifungal therapy even more with no impact on mortality. I just want to take you back to the seminal 2005 open label study performed by Professor Martens and colleagues in Belgium, the first biomarker study, no mold active prophylaxis, significant decrease in antifungal use. But I want to emphasize the fact that in this study, they had 10 patients, 7% of their population, who only started antifungals based on the biomarkers because they never developed fever. So fever alone is a suboptimal clinical trigger. Now, around the world, I think it's really the same situation everywhere. I can assure you in the UK, it's the same. Many of the assays I've just been describing, galactomannan, beta-D-glucan, PCR, are not routinely available. And even if they are available, we may not get them in a rapid turnaround time. So these two assays shown in the picture here are single sample, rapid lateral flow devices, the LFD and the LFA. I'll just show you some data here from hemato-oncology. So this study looked at BAL fluid, bronchoalveolar lavage fluid, from 64 patients with proven or probable invasive pulmonary aspergillosis and compared it to 117 control samples from patients with no evidence of infection. And you can see that both of the assays performed well in terms of their PPV and negative predictive value. Similar data has been seen in the intensive care unit setting, and in this setting, the LFD test showed very high negative predictive value. The utility of these tests in blood is still to be definitively established. So what about drug choice? Well, in terms of drug choice, I'm going to go to international guidelines because the guidelines are really very consistent. And in the empirical setting, I've used IDSA 2060 guidance for Aspergillus. And I'm sure you're all very familiar with this, that the range of drugs recommended in an empirical setting are shown here. Now, I should just emphasize that voriconazole does not have a license for empirical therapy of fever, but nevertheless gets a strong recommendation. So how do you choose? I mean, all the drugs are recommended. So how do you choose? Well, clearly, the most important factor is your local epidemiology. But getting local epidemiology on invasive fungal disease is a challenge. Your use of prophylaxis, as I've already mentioned, can have a profound impact on your choice of drug. And depending on what you're using, do you or do you not have therapeutic drug monitoring to know whether the levels are therapeutic or subtherapeutic? Do you have azole drug resistance? Because if you do, that's going to be a very important factor. And I've already touched on the issues of diagnosis. Clearly, if you don't have the drugs available to you, you cannot prescribe them. In terms of proven and probable aspergillosis, I've used three recent international guidelines here. They are entirely uniform. A recommendation for voriconazole or for isobuconazole based on a large randomized controlled study comparing the two drugs for invasive aspergillosis as well as other invasive mold infections. Now, the question obviously becomes, which drug should I use? So let's just compare isobuconazole with voriconazole. Well, the most noticeable difference in terms of spectrum of activity is isobuconazole has activity against mucorales. And in terms of formulation, it's both intravenous and oral. Its oral form is extremely bioavailable. And based on the pharmacokinetics, there's no indication that therapeutic drug monitoring is required for isobuconazole, so perhaps a significant advantage. And after initial loading, it's a once-daily dosing regimen. In the randomized controlled study, it was found to be safer and more tolerable than voriconazole, with in particular fewer liver toxicity side effects. Now, in terms of drug-drug interactions, theoretically, isobuconazole has a better profile than the other azoles. So I'd really like to finish here with showing you what we actually do at our center and changes we've made and the impact of those changes. Now, I've highlighted some of these controversies already, and I'll just talk quickly about how we've addressed them at our center. So we have guidance, local guidance, which I'll show you in a second, based on our local microbiology and clinical data. We use what I describe as a prophylaxis light approach and attempt to manage patients diagnostically. We have galactomannan and beta-D-glucan available largely on a twice-weekly basis with CT scanning. We do not use this in a screening strategy. We use this in a diagnostic-driven strategy. Fever in a stable patient. What's the right thing to do? And this is a real challenge in the hemato-oncology setting, and I'll touch on that. When to stop antibiotics, when to stop antifungals is a major, major challenge. The easy option is just to continue until the patient gets better. I don't think that's good clinical practice. Data is a major challenge in this area. So we are using an online audit tool, the Fungal audit tool for stewardship, which I'd like to present to you, but I probably won't have time at the end of the talk. And we're performing a retrospective, prospective, in-depth audit of the entire antimicrobial management of our patients in order to really understand what's happening and to make sensible decisions from there. Now, in September 2019, we made a major change of our febrile neutropenia guidance. And in a way, you could say it was an attempt to jump off that roller coaster I described before. So our high-risk patients are defined at the top of the table, acute leukemia and transplant patients. And we restrict antifungal prophylaxis now to the allogeneic stem cell transplant setting, and we use fluconazole. The only setting in which we use mold-active prophylaxis is acute lymphoblastic induction treatment, because the use of vinca alkaloids in the regimen makes the azoles impossible to safely use. And the other big change for us was that we stopped using routine fluoroquinolone prophylaxis, which up until that point in time, we had done routinely for decades in the high-risk population. So that antimicrobial roller coaster is beginning to look a bit different now. So you look at our prophylaxis, it's not what I showed before. For febrile neutropenia, yes, we certainly start broad-spectrum antibiotics immediately, but that box that says blood culture negative, well, we're beginning to see shifts in that. In fact, we're beginning to see more positives. Is that a good thing or is it a bad thing? Well, we can discuss that perhaps in the question and answer, but it has a profound impact on what follows and hence on antifungal management. So the guidelines are very much focused on what to do after febrile neutropenia, about when to stop antibiotics and when or not to escalate. So firstly, we're using combined piperacillin amikacin as an initial treatment, and we stop amikacin after 48 hours if blood cultures are negative for gram-negative organisms. Also, if blood cultures are negative, the patient is afebrile for 48 hours and clinically stable, we stop antibiotics regardless of neutropenia. Perhaps more controversial is the option of if after 5 days in a patient who has negative blood cultures is clinically stable but has persistent fever, regardless of neutropenia, we may stop antibiotics. And I just want to emphasize in terms of changing antibiotics, the bottom bullet point there, we emphasize not to change to carbapenem in a well patient who is stable for fever alone. So what has been the impact of some of these changes? Well, we looked at our E. coli bacteremia cases in patients receiving intensive chemotherapy or a transplant from pre the change to post the change. We identified 59 patients that met these criteria. Now, this rather busy table I'll just talk you through. So you can see here in this box, the left-hand column is patients who received ciprofloxacin prophylaxis, and the right-hand column is those who didn't. There are a number of demographic features at the top of the table, but let me take you to some outcome data. So admission to intensive care statistically was identical in the two groups, 5 with prophylaxis, 2 without prophylaxis, and hospital admission was also identical. So 33 days with prophylaxis, 35 days without prophylaxis in terms of mean. If we look at outcomes in terms of survival from bacteremia, you will see here that 7-day and 30-day survival was also identical between the two arms, as shown there, no statistical differences. However, when we look at microbiological data, you can see here statistically significant differences and really quite marked differences between patients with ciprofloxacin-resistant E. coli, 73% on cipro prophylaxis, and only 27% for patients without prophylaxis. Similarly, the marked differences in ESBL-producing E. coli, 33% with patients on cipro, 10% for patients not on prophylaxis. So our conclusion from this so far is that while we may be identifying more E. coli bacteremias, there is no change in outcomes in terms of survival, in terms of intensive care unit admission, but a very marked decrease in resistance. Is this relevant for invasive fungal management? What is optimal management? Well, reasonably, I would propose that what we're doing currently is optimal. So it's prophylaxis light, diagnostic driven, which is what I've tried to show you here. And the important thing I'm trying to emphasize here is it starts from the beginning. It starts with prophylaxis, be it antibiotic, be it antifungal. Our ability to detect bacterial infections is going to impact on the escalation or lack of escalation of antibiotics, and that's going to impact on the ongoing rates of persistent fever and hence antifungal management. For antifungal management, we should use where we can the tests that we have available. Now, I would love to show you data on the impact of our policies on the latter part of this diagram. Don't have that data yet, I'm afraid. The fungal audit tool for stewardship is being populated, and I would hope to have that data for you definitely for next year, if not before. But this is a fungal audit tool for stewardship. That web link would take me there, and unfortunately, I don't think I'll have time to show it to you now. And perhaps in the question and answer, I have some suggestions for you here. You may have, I hope, lots of other questions as well. I'd also like to know about your experiences. Are the things that I've described what you recognize, or is your experience completely different? If you would like to attend in person or online the fungal update meeting, we'll be running the 16th annual fungal update meeting next year in central London. Please do attend. do look at past meetings online, and you will find a wealth of information there. And this is a required slide at the end of a talk. So thank you for your attention, and I look forward to much discussion with Professor Chakrabarti in the Q&A. Thank you.
Thank you, Professor Agrawal, for such wonderful, interesting talk. Now we move to the second topic. It is my honor to introduce Professor Arunaloke Chakrabarti. Professor Chakrabarti is professor and head of Department of Medical Microbiology of the Postgraduate Institute of Medical Education and Research in India. He oversees the Center of Advanced Research in Medical Mycology, WHO Collaborating Center for Reference and Research of Fungi of Medical Importance, and the National Cultural Collection of Pathogenic Fungi. He also president of the International Society for Human and Animal Mycology, and was recently awarded the Mosselio Study Award from American Society of Microbiology. Let's welcome Professor Chakrabarti.
Okay, thank you. I've been asked to discuss a very important topic, that is the latest mold infection landscape and challenges, and what is the reality in case of Asia. This is the disclaimer. I would say that in Asian countries, half of the world's population live, and they face multiple challenges while managing mold infection. Because there is a problem which we face, overcapacity patient load. We have seen very high the mold infection, the high spore counts in the year of the hospital. We have seen a tropical environment in Southeast Asia where the fungi usually thrive, and large number of uncontrolled diabetic patients. So limited data showed that the rate of mold infection is very high. On the top of that, we recently faced this particular outbreak, that is COVID-19 associated mucormycosis, especially in case of India, and to a certain extent in Pakistan and Iran. It had shown that uncontrolled diabetes and steroid therapy was important risk factor. But two important things is that there is a delay in diagnosis, because large number of patients, by the time they reported to the hospital, they have got CNS infection. And because of this limited awareness, the outbreak recognized late. So these are the usual problem in Asian countries. Coming to invasive aspergillosis, here also I would say that the number of patients are increasing because of expanded population of immunosuppressed patients and new risk group. And here it is not Aspergillus fumigatus. In some of the countries, we have seen Aspergillus flavus is more common than fumigatus. And the parafungal disease, pitheosis, is an important challenge in case of Thailand and India. As we have got limited data, this is the Bongomin's paper in Journal of Fungi, where they projected the estimate data. And it showed that in Asian country compared to rest other continents is much higher of invasive aspergillosis. And in case of this other country-wise, when we have tried to look into in Asia, we found that certain countries, yes, the incidence is very high of invasive aspergillosis in China. But in case of the mucormycosis, that is the red bar, which had been shown in Pakistan and Iran other than India. So this is the concern of mucormycosis always being in Asian country, because what we have shown compared to the rest part of the world, we have 70 times incidence which is there. But this particular outbreak is unprecedented. It came as a storm. Some people describe it as a tsunami, because in this particular outbreak, in case of the government portal has reported nearly 50,000 mucormycosis cases. And this is the first time mucormycosis is declared as a notifiable disease. And in the same portal it mentioned, it is very likely that actual figures are considerably higher than this. So we conducted a study last year, multi-center study, which showed that COVID-associated mucormycosis prevalence is 0.27% of the COVID patients treated in the hospital and 1.6% those treated in ICU. Nasoorbital mucormycosis is the commonest group, And here, as I've already mentioned, you can see quarter of them have already brain involvement. So they came to the hospital late. And multivariate analysis showed hypoxia and inappropriate steroid therapy are the important risk factor. But what we have seen this year, especially from the April to May, is really unprecedented. You can see the incidence has gone very high. And other than diabetes and steroid, what we found also that the environmental mucoral spore count is very important. And you can see the mortality is nearly 50% in 12 weeks. The crisis was so high that there was no antifungal drugs which can be given in case of mucor. So the first-line therapy, liposomal amphotericin B, was not available. So we give a restricted this particular protocol or algorithm. We said that go for, if you have no liposomal amphotericin B, go for amphotericin B deoxycholate or isavuconazole or posaconazole as the first-line therapy. Even nothing is available, we have even suggested to give itraconazole, which was never being recommended in case of the mucormycosis patient. Friends, after this mucor, another issue which I like to bring out in case of the Asian country, which is very important, is the chronic pulmonary aspergillosis. We have large number of tuberculosis patients, and post-TB, this development of chronic pulmonary aspergillosis is a major factor. You can see compared to the other part of the world, in Asia, it is much higher. And in case of this bar diagram, out of the most important 7 countries, 6 are in case of Asia. Now look into some of the multi-center study which is available. One is in case of the hematologic malignancy, which had shown that in case of the fungus which are causing the infection, mold infection, especially aspergillosis, much common or much higher in incidence than candida. This is our Asian Fungal Working Group study to look into invasive mold infection. What we found, as usual, hematologic malignancy is the major group. And here AML is the major factor, that is the acute myeloid leukemia patients are commonly suffering from fungal disease, but diabetes is also an important risk factor. As I've already mentioned, Aspergillus flavus other than fumigators can also be important, and mucormycosis in 10.2%. But other than AML, even what we have found that nearly 20% of cases are in lymphoma. It can be a new risk group. And you can see the challenge in case of therapy. Though we should have recommended liposomal amphotericin B, rather it is amphotericin B deoxycholate has been used in considerable number of patients. Now, looking into this autopsy data, though it's a little older data, but this particular data is autopsy data which can really confirm cases of invasive fungal disease can be documented. It showed that 29% amongst the hematologic malignancy. And here, aspergillosis is equal to candida. And that time, we usually not giving so much of prophylaxis. As we have started giving prophylaxis, mold infections are rising and rising. Even then, mucormycosis was in 10%. So, more recent data shows in the same center, there is around 40% cases of fungal infection. And you can see both Aspergillus and mucor which have been there. At our center, when we have compared to the Western world, we found it is more than 2 times incidence in invasive fungal disease. The reason is we are giving induction chemotherapy in case of the patients in general ward without HEPA filter because of the resource constraint. And because of this, there is delayed diagnosis and longer time for remission is an important issue. Coming to the pediatric age group, this is a study from New Delhi where it had shown that in febrile neutropenic group in children, nearly 1/4 of them has got invasive fungal disease, and aspergillosis is the commonest one. In our center, where we have looked into both AML and ALL group, here the incidence is around 7%, where aspergillus is the commonest fungi. In the allogenic transplant group, compared to the USA, Italy, or Brazil, look into the Asian country. Incidence is high, and we have got large chunk of aspergillosis, and then it is the mucormycosis which has been there. Other than classical risk group, look into this ICU group. In case of ICU, this is a multi-center study which we have done for invasive mold infection in India, where it had shown that 9.5 invasive mold infection per 1,000 ICU. But point of what is that overall mortality is around 67.3%. And those patients who are even treated, there is mortality 65%. So friends, what I try to say is that we need early diagnosis. And in case of India at least, we have shown other than Aspergillus, mucormycosis is an important factor. So we have the challenges for high mortality, high burden. For this, we need early diagnosis and prompt therapy. We know that the conventional diagnosis is poor sensitivity, long turnaround time. We need this non-culture based diagnosis, but it is not available in most of the laboratories because we have got fully equipped laboratories are very few in number. Therapy-wise also a problem. We know there are very few antifungals available. Even those antifungals are not available in all Asian countries. And when we are thinking of these water insoluble drugs, especially these antifungals, we need to have the viability by checking also the therapeutic drug monitoring. Only in fluconazole and isavuconazole, which are water soluble, possibly we don't need the therapeutic drug monitoring. But these facilities are not available. Look into the progress in diagnosis. We have got this T2 magnetic resonance imaging for diagnosis in blood culture, which is still not available in Asian country. MALDI, one of the very important equipment which can diagnose or identify mold within few minutes, that is available in few centers. But there is some improvement with this lateral flow assay, which is rather a point of care test, which might be the answer for the future because it is rapid and also cheaper. So if we have to implement the gold standard in case of fungal diagnosis and treatment, the challenge what we are facing is high burden, limited awareness, low resource allocation, public response is poor, local epidemiology data not available, limited diagnostic, and the issues of antifungal drugs. So we did a study in 7 Asian countries to understand what is the present status. We found that in case of this, non-culture-based diagnosis are available less than 25 centers. In case of 25 centers, that is there. And even when we looked into the clinician, how much they are trained, we found 63% had no formal training in medical mycology. And because they have got very few diagnostic mycology laboratories, they are mostly giving empiric therapy. They are getting very few cases of proven invasive fungal disease per month. When you ask them what therapy they like to give, here what they found that factors preventing use of preferred antifungal is that patient cannot afford. So what they want is that they want improvement in diagnosis, they want training courses, they want there should be institutional and national guidance. So friends, where to go from here? First important slogan is stop neglecting fungal. Second thing is that we need to improve advocacy. And already this advocacy has helped. Look into this WHO-sponsored essential diagnostic list. Many of the tests which was not earlier there are now included. Similarly, in case of medicine list, there is improvement in case of antifungals have been included in the essential medicine list. But what I like to say is that when you don't have a specific fungal program in your country, at least what you can do is that you can piggyback already having the program like HIV, TB, blindness. All these issues, fungus is important one. We need to improve the training of the laboratory personnel and clinician, and we need to develop the diagnostic laboratory and availability of the antifungal in most of the center. So with these gaps, what we thought that there should be some light at the end of the tunnel. So we developed this Asian Fungal Working Group. The Asian Fungal Working Group main motto is education, training, research, and community network. You can see already this particular training program, that is Medical Mycology Training Network, as well as FWG master classes, had trained more than 2,500 clinician microbiologists. You can see they have conducted 17 medical mycology training network courses. And also they have published so many papers. All this has helped in case of understanding what is the scenario in case of the invasive mold disease in Asian countries. Finally, I'd like to invite you. This is the first time we are going to have, in case of the India, this World Congress of International Society of Human and Animal Mycology. That will be in 20 to 24 September 2022. All of you must participate. Thank you for your kind attention.
Thank you so much for Professor Chakrabarti's wonderful and comprehensive presentation. Now, I would like to invite Professor Agrawal and Professor Chakrabarti for the fireside chat and the Q&A section. I also invite all the audience, friends, experts, please submit your question. May I ask the first question? This question from the audience to Professor Agrawal. I just wonder what the practice in your site is. This uniform in UK or individualized? And would you please give us more explanation regarding the preemptive therapy in your site as well as in your country, as UK have very similar national health insurance system as Taiwan. So I just wonder, please.
Okay, thank you very much for that question, Professor Chen. Very quickly, it's always a pleasure to be on the same platform as Professor Chakrabarti and yourself. So thank you very much to Pfizer for the invitation. Really good question. I'd just like to, before I answer that question, I just want to show 3 slides about diagnostics in the UK so that my colleagues in Asia can see that perhaps things are not quite so rosy as you might expect in the Western countries such as United Kingdom. So this is a study published recently about national mycology services across the United Kingdom. Next slide, please. 154 laboratories in the UK have diagnostic capacity mycology. Half responded, so that's actually a very good response rate for a survey such as this. And I'll just very quickly show you the headline data on the next slide. Now, this busy table I've summarized here. That's fine. If you just click on, thank you. So of the laboratories that replied with respect to beta-D-glucan, so these are laboratories who perform the assay in-house on the hospital site. You can see 5% of centers of testing laboratories offered this. Galactomannan, 21% of respondents, and even less if it was a BAL fluid. PCR, well, as far as Aspergillus PCR or Candida PCR, effectively is not available locally at most centers. Pneumocystis is slightly better. Next slide. And in this, this is unpublished data. Well, it's published online at that reference there. This is a questionnaire, if you'd just like to press the next button, done by the NHS England, looking at the turnaround times for antifungal tests when they were sent to reference centers. And what you see here is for galactomannan, beta-D-glucan, lateral flow assays, fungal PCR, that red box is showing you those centers that got results for these tests back within 72 hours. And next button, please. Sorry, there should be one more slide. Oh, I can't see it because it's hidden on my screen. But this represents only 12% of all centers. So even in our scenario in the UK, fungal diagnostics are really suboptimal. And so every center, you can see on this, has a very different capacity in terms of fungal diagnostics. And what happens is unique at each center. So what I've presented is very much what we are doing at our center. And the way to talk about preemptive is a little bit unfair in what I've presented, because we are not using beta-D-glucan and galactomannan in a screening strategy. And we did screening back in 2008, if I recall, 2006 to 2009 with galactomannan. And we didn't find it clinically useful in our practice. We stopped doing it. What we have now is a diagnostic-driven strategy. So at the time of clinical symptoms or signs where we're suspicious, we may be dealing with a fungal infection, we order galactomannan and we order beta-D-glucan, and we have these available twice weekly, which immediately tells you we don't always get them back in a timely fashion. So it's very much what we're doing. It's not what everyone else is doing.
Thank you. How about the Professor Agrawal's the limitation or the gap between the reality or from many hospitals? I just wonder, our mycologist, Professor Chakrabarti, what your suggestion or what you can help for clinician at the bedside?
I would say that in case of these challenges are there. There are some improvement which is coming in case of fungal diagnostics. And this improvement is, means I have shown usually, I showed that particular slide in different lectures that in MD Anderson, in last century, they used to have almost 90% of their invasive fungal disease diagnosis in case of postmortem, and which had improved significantly in this century in the first 2 decades. And these improvements had come because of the biomarker test. And these biomarker tests, what Dr. Agrawal just mentioned or showed in UK, is similar in picture which is in case of Asian country, because the data which I presented in my presentation of the Asian Fungal Working Group of the 7 countries, it is in the same situation. So what I generally feel is that the lateral flow assay, which is coming up, see that crypto, a lot of people have shifted from the antigen, which they used to do earlier by doing with the ELISA method or by latex agglutination method. Now the laboratories are doing lateral flow assay for crypto. Similarly, in case of the Aspergillus, there are 2 lateral flow assay procedures are available. One detecting the antigen for the protein, another is for galactomannan. I presume this lateral flow assay would be much cheaper and which would be much more affordable in most of the centers. So that is one important development which possibly in Asia would really improve in case of diagnostic. Second thing is that, of course, the CT scan, which is already been discussed by Dr. Agrawal in his presentation. But I would say another aspect is that if you can do the bronchoscopy, at least in our center, what we have found that is one of the technique really improved. The EVAS technique has improved. It's not very expensive technique. It is only you need a fiber optic bronchoscope and for a biopsy to be taken. And this particular technique has improved our pulmonary mycosis diagnosis in a very significant way. So you see that we have no alternative other than improving the diagnostics. Otherwise, what Dr. Agrawal mentioned will be in that roller coaster. We'll be giving on going antifungal and antifungal and antifungal when there is no response to antibacterial. So there is a need of improvement of the diagnostics, that is very clear. And how we can balance this, that's why I've said that these are the ways we can possibly balance this scenario.
Thank you, thank you. There's come another question from the audience for Professor Agrawal, pertaining to the updated institutional guideline that you presented. How was the clinician buy-in to using a more restrained policy?
Yeah, I mean, that's a really good question. And I think that comes to the nub of it. You know, we're very focused in meetings like this on the diagnostics and getting a bit more high tech. Firstly, I completely agree with Professor Chakrabarti that bronchoscopy is a really key investigation. And even in patients, hemato-oncology patients having had intensive chemotherapy, they can have a bronchoscopy, the vast majority of them. So it's a really key test to perform as early as possible, rather than waiting for the patient to deteriorate and you've already treated them for everything, so it's not diagnostically useful. But so the question relates to human behavior. This is about how do you engage with doctors looking after patients who are not well to suggest that they, in general, don't do something or stop something. And that's very challenging. And if the role of stewardship was to suggest increasing things or adding things, the clinicians would find that easier. So it's a really difficult scenario. And the answer is we changed the guidelines through multiple iterations of meetings and of email exchanges. So that's how we got consensus around it. And that consensus was driven by an increasing awareness around antibiotic resistance, an increased awareness that perhaps broad spectrum antibiotic prophylaxis was not necessarily the right approach. And so, you know, that was a slow process. And having done that, and now that we've been doing it for 2 years, and now we're getting data out, we can see that this approach seems to be safe and it appears to be beneficial in terms of decreasing antibiotic resistance. Now, the reason that's so important for fungal management is that if you do not know why the patient has a fever in the vast majority of your patients, then you get to the point of persistent fever, unaware of anything that's going on. And what Professor Chakrabarti just mentioned is the roller coaster. You start treating empirically with antifungals. If you never ask yourself the question, when am I going to stop? How will I stop? Yeah. Then you're basically saying, from the day the patient comes in, we will start antimicrobials. Until the day they leave, we will have them on antimicrobials. Now, you might be happy with that as a general approach, but that is not good clinical practice. And you would never treat a patient with leukemia without knowing exactly what the leukemia was. You wouldn't treat the patient with lymphoma without having made a histological diagnosis. I think we have to be honest with ourselves and say we need to do better when it comes to infection management. You know, and part of that is realizing that the sort of patients I look after will all get fevers. I mean, getting fever after intensive for febrile neutropenia, well, you're neutropenic, so you get a fever, is normal. What you have to do is realize, work out who is deteriorating, who is unwell, who needs escalation. The tests are very important, but our clinical acumen is really our key guide. And we really must look at how the patient is before jumping to change. And, you know, that takes time. You know, people have to become confident with what's going on. And we're finding people are changing, and it does take time. It's not always easy. And I'm not always very popular with my hemato-oncology colleagues, who don't always feel that someone else coming around on the stewardship round with infectious disease colleagues and pharmacists have got anything to offer them. So, you know, it's not easy. It's not easy, but we can get there, and we are getting there.
Thank you for pointing out the human behavior. Although we are facing invisible pathogen and difficult to diagnose, but the human behavior, how do we recognize the situation, is very important. I think many physicians are not aware that antimicrobial use itself is a risk factor for infection because we interfere the microbiota. In recent years, more and more knowledge regarding the microbiota support the use of antimicrobial agent. However, few are colleagues aware of that. So, beside cross-observe, the patient condition is very important. However, we still need a good diagnosis to explore, identify the etiology of fever. Thank you. And we have more questions. Would you talking about, do you use anti-active prophylaxis as well as TDM in your institute? because the limitation of diagnosis, especially in the long weekend and others consideration.
So if that's directed to me, then
yeah, please.
Okay, so I'll answer that very briefly. So antifungal prophylaxis, if I heard the question correctly, yes, we principally use fluconazole. So we have very little anti-mold prophylaxis in our hemato-oncology unit, and that anti-mold prophylaxis is specifically in induction treatment of acute lymphoblastic leukemia and for patients with graft versus host disease following allogeneic stem cell transplant. In all other scenarios, AML treatment, allogeneic stem cell transplant, we use fluconazole. In terms of therapeutic drug monitoring, we do use it, but as you can see from what I've just said, that we don't often need it in the prophylactic setting. Equally, however, in the treatment setting, if we're using an azole, voriconazole, posaconazole, even isobuconazole, then we do get levels done. Yeah, so that's our practice at my center.
May I ask Professor Chakrabarti, regarding from your perspective, as you mentioned, the mucormycosis burden in Asia is tremendous. Therefore, it is from your perspective, do you consider the azole, which is active against mucor, such as isavuconazole, has some role for more active prophylaxis in your patient population?
I would say that in case of the prophylaxis wise, in case of the mucor, that's a different question. Mucor, that outbreak and all those issues are a different question. But if I have to say about the hemato-oncology group, which Dr. Agrawal just mentioned, Indian scenario or Asian scenario is a bit different from possibly UK. We have a very high spore count in the environment. And you know that these patients, even when they are in induction chemotherapy, they are not put in the HEPA filtered room. Possibly that is the reason that whether it is in case of India, at least we have got the data from southern part of India, from Vellore, then from All India Institute, Delhi, and also in our center, we found mold infection rate is increasing rather than east. So we, in general, prophylaxis-wise, we are going into more to the mold-active prophylaxis, and generally we are using the posaconazole or voriconazole. These are the two things which we are using. But when you are asking about isavuconazole, till now isavuconazole as a prophylaxis, we have not used this. I'm not very sure of the whether that is being used in Singapore and other. It has been used in case of the US, but there are some mixed results are there. So we need much understanding in case of isavuconazole, in case of the prophylaxis. But I would say that isavuconazole, this time during our outbreak, we found a tremendous importance, especially in case of mucor. Especially, you all know that there was a serious outbreak happened of COVID-associated mucormycosis in India, when the first line therapy, which is being recommended by most of the guidelines, is the liposomal amphotericin B, which was completely not available in India. So we had no alternative other than using the azole as the primary therapy, either posaconazole or isavuconazole. And what we found that in some of the patients where the posaconazole developed toxicity, or we usually do therapeutic drug monitoring, and posaconazole was not achieving the target, some of the patient, even we have to shift to isavuconazole. So I would say that was a forced indication, where though it was not very clearly indicated, it was some B2 recommendation in our global guideline of mucor. But now possibly this particular data which we are going to publish, which we are already analyzing the data, and that would really help us to know what is the role in case of the primary or first line therapy of mucormycosis with isavuconazole. That would be very important data. Otherwise, the isavuconazole, because of this water solubility and good viability, less drug interaction issue, all this has helped us in case of giving this particular therapy. but we could not do any RCT, which was really very important to do an RCT in understanding whether it can be given isavuconazole. That was really lagging because even Pfizer was in crisis with isavuconazole. So you can imagine that nearly 100,000 mucormycosis cases came suddenly all together. Thank you.
Thank you for highlight the challenge we are facing at present time. I think it's very unusual comparing to Professor Agrawal mentioned. We follow the guideline, which was developed based on well-designed clinical trial. However, during disaster, we need to prompt reaction based on some in vitro data and others, especially during COVID-19. Thank you. It's very special. It's time to okay. I just really enjoy the lecture from our speaker, Professor Agrawal from West, and Professor Chakrabarti from the East, who meet together in this fire chat. It is my honor to chair this section, and thank you for all the audience, expert and friend in the crowd to join us in a very active interaction and pose some very interesting, challenging question. And because next week is World Antimicrobial Awareness Week, and our both speakers are expert in this field. So I strongly recommend every one of you continue the information provided from our two speakers. We can work together to combat the antimicrobial resistance. This is a global crisis. So I hope you learn a lot from our speaker and you can contribute further all together, especially Professor Chakrabarti, our current president of Asia. You can see his enthusiasm and commitment to push us work together to improve the diagnosis and the treatment of fungal infection in Asia as well as globally. Thank you. Thank you, Professor Agrawal and Professor Chakrabarti. And thank you all audience.
Thank you.
Please. Thank you.
Thank you.
And please, please complete the feedback survey. It is important for us, especially for Pfizer, who continue support our education and in Asia. I think in other countries, we need your feedback in order to design our further lecture. Please. Thank you again for every one of you.
Thank you.